So, dear ladies and gentlemen, welcome at the next EFIM webinar that's organized by the Young Internists. This time is thanks to Kristina Severval from Sweden, who's responsible for organizing tonight's event. At the beginning, first let me introduce my co-chair, Dr. Andrea Salzano, who's working in the internal department in the Naples in Italy, and he's doing a research in UK. My name is Zora Lazurova. I'm working in the internal department at the University Hospital in Košice in Slovakia. So before my co-chair would introduce the speaker, I would like to just remind some instructions for the audience. If you have any questions during the presentation and the lecture, you can use the chat here at the Zoom, so you can write your questions anytime, and then me or Andrea would read these questions to the speaker, who would be very happy to answer all of your questions. So Andrea, please.
So hi to everybody, and thanks Zora to introduce me, and I again thanks the Young Committee for this invitation, and it's my great pleasure to introduce the speaker of today, that is Dr. Erik Ulmark, working at the cardiology department at Scarborough Hospital in Sweden. He's a specialist in general internal medicine and in cardiology, and he has been in charge for more than 10 years for his hospital for the CPR education. So it's a very expert in the field, and so it would be a great pleasure to listen what he can say, and I hope that all the audience, I'm sure, sorry, that all the audience will enjoy this great lecture that we have tonight. So please, Eric, when you want, you can start. Thanks.
Thank you, Andrew. That was very kind. Let me just share my screen. And here we are. So thank you for having me. The one disclosure I have to make is that you're just looking at a picture of most of my next door neighbors. I have no academic merits to speak of, really. I don't have any titles at all, but I've read a lot about cardiac arrest. I've thought a lot about cardiac arrest, and I've taught cardiac arrest for more than 10 years. And I'm quite good friends with certain people who are quite a lot more smarter than I am, one of which is Therese Järv, who's a professor of emergency medicine in Stockholm and a member of the ERC Guidelines Committee. And we've done quite a bit of work together on cardiac arrest, some of which I'll show to you towards the end of this lecture. So I hope that you'll find it worth your time listening to this, even if I'm not a professor. So we're going to talk about cardiac arrest. This is important. People who come into our hospitals every day, they trust that everybody who's dressed in scrubs can take care of them if they drop dead. I think that's a reasonable expectation, and I also happen to think that it's a privilege that people trust us this way. It's one of the best things we get to do at work is to actually save a life, and sometimes we really do, and it's very palpable and very concrete that somebody drops dead, and once we do the right things, then we make them live again. That's pretty much the reason why everybody practices medicine, I think. And I'd argue that if you're a doctor working in a hospital, knowing your ACLS is the bare minimum that's reasonable to know. And if you're an internist or a cardiologist, you're probably one day going to be the person who's called when the guidelines aren't enough, when you need to go beyond the guidelines and do something more. So if you don't know your ACLS, I'm not going to tell it to you now, but you need to know it once you get on shift the next time. Everybody who takes part in resuscitation should know these things in the middle of the night without having any notes or anything. And we're going to talk a bit about why the guidelines are the way they are, a little bit about the controversial things in the guidelines, and a little bit about what I think is the future of resuscitation. Well, we'll start here. You see two rhythm strips on your screens, and just take a minute and think about which one is the most common in cardiac arrest. These are numbers from the Swedish CPR registry. These are from 2017, but it hasn't changed much since then. And these are in-hospital cardiac arrests, about a quarter of every cardiac arrest in hospital is shockable. The out-of-hospital cardiac arrest numbers are similar. In 2016, 21% of cardiac arrests pre-hospital were shockable. This is a bit strange if we consider what we practice. Most of the time we practice taking care of shockable cardiac arrests. And one of the reasons for that is that the prognosis is a lot better if you have a shockable rhythm with a cardiac arrest. Things quite often go quite well for people with ventricular tachycardia or ventricular fibrillation. The non-shockable rhythms have a much worse prognosis, but maybe that's where we come in. Maybe we can do more for those patients. That's a lot harder to practice though, and I think that's the main reason why most cardiac arrest training is for shockable rhythms, because we have a really good treatment for those patients. And this is the most important thing about shockable rhythms, that this is the basic stuff. We need to do compressions and we need to give them electricity. We have a perfect treatment to offer our patients with shockable rhythms. There's absolutely no point trying to be clever or heroic or just show how bright you are if the person has BF. We need to do what we know works, and we need to do that maximally well. Having said that, there are still some things a little bit controversial in the treatment of shockable rhythms and worth discussing. The first thing to say is something about adrenaline. This is the Paramedic 2 trial, which was published in 2018 and led to quite a few people arguing for the removal of adrenaline from the cardiac arrest guidelines. It wasn't removed. And I think that was a good call. But we'll talk a little bit about this trial. This is a marvelous study. They managed to include more than 8,000 patients, and it was randomized, and it was blinded, and was placebo controlled. And they managed to do all these things while performing resuscitation pre-hospitally. There was actually a big process within the UK community where members of the public were involved, discussing whether this was a trial that was worth making and whether it was ethical. And this is the most impressive cardiac arrest trial I've ever heard of. What it showed was, and you'll have to excuse a few slides with a lot of text here, there won't be many of them. What it showed was that if you give epinephrine or adrenaline to people in cardiac arrest as per the guidelines after 3 shocks, or straight away if you have a non-shockable rhythm, you need to treat 112 people to have 1 extra person survive. However, there were more survivals with poor neurologic outcome in the epinephrine group. And this caused quite a bit of a stir, and some people said that we should definitely not give adrenaline because we're not going to cause any survivors who have a good neurologic function. We're just going to cause people who don't want to be alive. I think that's wrong. And if we look at the Swedish CPR registry numbers, there's a good argument for adrenaline being there. What you see to the right, bottom right of your screen, are numbers from the Swedish out-of-hospital cardiac arrest registry, which shows cerebral performance category, which is the most common outcome measure neurologically after cardiac arrest. CPC1 is basically no or very mild symptoms. CPC2 is some neurologic symptoms, but you're still able to work if you have adapted tasks at work. And if we compare the Swedish survival to the placebo group of the Paramedic trial, we see that in Sweden, we don't really have a lot of people who don't have a very good neurologic outcome. And Sweden and England are quite similar countries in most aspects, but one place where we differ is that in Sweden, we're actually better at doing bystander CPR when somebody has a cardiac arrest out of hospital. In Sweden, the number for that is 75%, whereas in the Paramedic trial, there was 50% of bystander CPR. And I think that's the main reason why the Paramedic trial looks worse than Swedish survival does. If the person is about to be dead, then maybe adrenaline won't work. But if we perform good CPR, then there is a role for adrenaline, and it still is in the guidelines. And for what it's worth, I think it was the right call, and it has a better chance to work if CPR is started early. And the main thing we should do with regards to out-of-hospital cardiac arrest is to try and improve bystander CPR. 50% is not very impressive. The other drugs that are still a part of the guidelines are Amiodarone or Lidocaine. And this is another very good study that's worth knowing about, which was conducted in North America and published in 2016, where they actually managed to do a three-pronged study where the people were given either Amiodarone, Lidocaine, or placebo, as per the guidelines after 3 shocks and after 5 shocks. It showed no difference in survival between any of the groups. So some people argued for Amiodarone to be removed from the European guidelines. It's still there, and the reason for that is in the subgroup, which was pre-specified in the study, in the subgroup of witnessed cardiac arrest, there was an absolute survival benefit of 5%, a number needed to treat of 20 for either Lidocaine or Amiodarone. And this says the same thing to me, that if a heart is dead, then it's dead and you can't do anything about it. But if you're there early and treat the heart early, then I believe that Amiodarone works. I believe that Lidocaine works the same. And this was actually a very good trial that showed that there was no benefit to Amiodarone over Lidocaine. It doesn't really matter much in Sweden, and I don't think it matters much in many countries. But Amiodarone is more difficult to store. It doesn't last as long. So in more resource poor settings, it's a very good knowledge to have that Lidocaine works just as well or just as bad as Amiodarone. It wasn't studied in this trial and not in any other big trials either, the combination of Amiodarone and Lidocaine. We don't know if that would provide any extra benefit, but I have to say that I find it hard to see somebody fibrillating to death without trying everything I have. And that's what we do in the cardiac intensive care unit if we have a patient with electrical storm. If we can't treat that with Amiodarone, then we give Lidocaine as well. And that's probably a reasonable thing to do if you have nothing else to do, but there's no support in the guidelines for that. Most importantly though, pick the lowest hanging fruits first. There's no debating at all that compression pauses are bad. In 2010, the European Resuscitation Council guidelines started advocating for us compressing while we charge the defib. Even doing that, however, there's still quite a bit of hands-off time where we cause absolutely no flow. And this is a schematic graph from a classic pig study showing the coronary perfusion pressure and how it relates to compression pauses. So once we stop compression pauses, the pressure in the coronaries drops really quick, and then it takes a few seconds to build up again. And in this study, they showed that unless the coronary perfusion pressure is sufficiently high, we won't succeed in defibrillating a ventricular fibrillation. There are a couple of really good studies from Norway where they've managed to study cardiac arrests pre-hospitally, showing that ventricular fibrillation changes amplitude and appearance during compression pauses. And from these studies, they could see that basically the higher the amplitude of a VF, the better the chance of converting from fibrillation to organized rhythm. And they could see that certain VF patterns have a greater chance of being successfully defibrillated. In a follow-up to that study, they checked what happened with the amplitude and the waveform of fibrillation as compressions were paused. And if you look then at those, the most benign ventricular fibrillations, those with the highest amplitude and the best waveforms, the chance of them deteriorating over time was really big. So that the waveforms that had the highest chance of conversion, the probability of a successful conversion halved with just 5 seconds of compression pause. So this makes a really big difference. And that has caused some people to argue for what's called as pre-charging the defibrillator. Some of you will have heard of this. And the point of this is to get fewer interruptions because you don't pause as often. And when you pause, maybe you can do it shorter. So less hands-off time overall. So instead of just doing compressions, pausing for analysis, and then doing compressions while the defib charges, you charge the defibrillator when you have 20 or 30 seconds left until a rhythm check, and you leave the defibrillator charged. And if the rhythm is still VTAC or VFib, you don't have to do another pause. You just shock and then you start compressing again. The most recent guidelines, both from American Heart Association and from ERC, say that this is a reasonable thing to do, but that the evidence in favor of this is too weak to actually recommend it. In the first draft of the most recent ERC guidelines, which was open for public comment, they said that they recommended against this, which was, in my opinion, quite strange. I've read the same studies as they cited in these draft recommendations, and I've read them completely differently. However, this was open for public comment, and I think that I wasn't the only one who commented that this was a reasonable thing to do, and it was actually changed within the guidelines, which I think is a very good strength of these guidelines, that they listened to people who take care of a lot of cardiac arrests. So what they say now is that if you have a well-trained team and you can do this safely, then it's a reasonable thing to do. And this isn't difficult to do. If you just have good communication in resuscitation, there's absolutely no problem doing this. And if you don't have good communication, then most things are going to be difficult anyway. So you need to have good communication. Basically, what you do is you say, Jenny, just keep compressing. The defib is going to beep. I promise I'm not going to electrocute you. I'll let you know once you need to step away from the patient. Just ignore the defib and listen to me. And that works well. It works well even if you haven't practiced it as a team, which you should do. If you just communicate well, this is quite easy to do. So just charge the defib, analyze the rhythm. If there is a ventricular fibrillation, shock it and resume compressions. If the rhythm doesn't need a shock, there is a button on all modern defibrillators where you can release the charge without any current going out into the room. So look at your defib and make sure that you know where the button is. How about coronary angiography, though? This is quite hip. It's cool, and people like doing PCI. During CPR, without return of spontaneous circulation, there is absolutely no good evidence at all supporting doing coronary catheterization. But there are plenty of case reports. And I've taken part of a resuscitation where we took a patient in VFib to the cath lab, and we opened the blocked LAD, and we got ROSC, and everybody was happy, and we feel like heroes. But the little evidence there is for this suggests it doesn't work. They did a very pragmatic trial in Gothenburg in Sweden 6 years back, I think, where the ambulance crew were allowed to just phone in to the cardiologists on call if they thought that the patient didn't look too old, which was up to the discretion of the ambulance crew. And then the cardiologist in call said that could either say that, well, yeah, the cath lab is open, just come straight in, or no, we can't do it right now. And then the patient went to the ED straight away. So it was very pragmatic and not too scientific. The main finding from this case series, though, is that they had no patients who survived who didn't get ROSC before they arrived in the cath lab. So there's no good argument to be made that this should be a routine intervention for people with refractory ventricular fibrillation. On the other hand, if the patient is too young to die, doesn't have too many diseases, and the cath lab is open and you don't have to wait 45 minutes for people to get in, I'd find it hard not to try and do an angiography if I can't treat a VF once we do the basic stuff really, really well. As coronary disease is the overwhelmingly most common reason for shockable cardiac arrest. The hippest flavor of today, though, is this eCPR or ECMO-assisted CPR. One of the arguments against doing coronary catheterization intra-arrest is that maybe it won't work because you can't perfuse the heart enough and the patient will be dead before you can open a blocked vessel. eCPR would take care of this problem, basically using ECMO as support while trying to cure the cause of arrest. There has actually been one published randomized study for this now, which was in The Lancet in 2020. And in this study, they showed a survival of 43% if you did ECMO CPR as compared to 7% without ECMO CPR for refractory ventricular fibrillation, which is defined as VF that persists after 3 shocks. However, this study was stopped early after only 30 patients were included of the planned 150 because the monitoring board thought it was unethical to continue as there was such a great survival benefit. And this is very problematic because the sample is too small to actually believe the effect size, but the study is large enough and big enough to make it quite difficult to study this further, I think. It will be hard to get ethical approval to do a randomized eCPR trial once there is a resoundingly positive trial that has already been published. The other thing to know about this is that this was done in Minnesota, which I think is one of the best ECMO systems in the world. So everybody was well drilled, and this is absolutely a best case scenario. And people could only be included if they had a predicted transport time of less than 30 minutes to the ED. And in the ED, they had fluoroscopy and they had ECMO teams ready to cannulate. So this is really the best case scenario, but this is probably part of the future. And if you work in a place where ECMO is a possibility, then make sure you make ECMO contact early, because this needs to be done quick if there's going to be a benefit to it. My friend Therese works in Stockholm, where they do a bit of ECMO CPR. I've never been involved in an eCPR case because I live in Skövde, and we have, on a good day, an hour and a half to the nearest ECMO hospital. But in Stockholm, they've done this a little bit over 200 times, she told me. The main thing to know from the series there that she has gone through is that they had 3 people dying on the ECMO from untreated pulmonary embolism. In this arrest study, only VF were included. And I think if you're going to start doing ECMO CPR, that's where the money is, because then you can support circulation, take people to the cath lab, hope that they have a blocked coronary vessel and open that. But if you do that, don't forget to look for the other stuff as well. This was the last I had planned to say about ventricular fibrillation, which will have to be illustrated by this nice little VF dance. And let's see if there are any questions so far. The only question I have right now is somebody who asks if you can get the slides for download. You can't actually, because there's going to be quite a few video clips and they don't really work well as a download. So we'll move on to the more difficult things instead. Then we're going to talk about PEA, or pulseless electrical activity. This has a much worse prognosis than ventricular fibrillation or pulseless VTAC. In hospital in Sweden, about 20% of PEA patients survive. Out of hospital, about 5%. And this is quite difficult. The definition of PEA is that you have a rhythm that you expect to give a pulse, but it doesn't give a pulse. So the fingers are what defines PEA. So how good are we at feeling for a pulse? Has anybody calibrated their fingers for that? From everything I've read, I've only managed to find one study which actually examines this, and that was from 1996, which is a great study to have done. They took people who were trained in CPR but weren't medical personnel. So they had emergency medicine technicians in training. They had lay people who had done a CPR course, and they had paramedics in training who'd done a CPR course. And they were all taken to the thoracic OR, where they stood at the patient's head and tried to feel the carotid pulse while there was a screen blocking the view of the heart. And the people feeling for the pulse, they didn't know if medications to stop the heart had been given. And they had quite a good sensitivity to feel pulselessness. So they detected pulselessness in 90% of cases, which means that they only found a pulse that was non-existent in 1 out of 10. However, the specificity for pulselessness was 55%. So they missed almost half of the people who actually had a pulse, and they deemed them to have a still standing heart while the heart actually was beating, and the invasively measured blood pressure was at least 80. If you look at the same study and just look at the results that came within 10 seconds, the participants in this study were able to accurately decide if there was a pulse or not within 10 seconds in 15% of cases. And 10 seconds is a long time to feel for a pulse. We're supposed to have absolutely no more than 10 seconds to feel for a pulse with rhythm checks. So this is hard. My strategy for quite a few years have been that there's always an anesthetist in my cardiac arrest cases, and he or she is at the head of the bed anyway. So I cross my arms and I say to the anesthetist, can you see if there's a pulse? And then I don't have to feel it. The thing is, with PA, there can be different things. These two ultrasound clips are from two different patients in Skövde. Both of them are in cardiac arrest, which is none of them is breathing, none of them is awake, which is how we define cardiac arrest. Both of them have an organized rhythm, none of them have a pulse. I think that everybody who looks at this, no matter how much ultrasound training you have, can see that there's quite a big difference to these two hearts. The one on the left actually beats, and the one on the right doesn't. And the slight movement you see in the right picture is just from the probe sliding into place. This has been shown to be a decent prognostic marker intra-arrest for who gets ROSC, not a very good prognostic marker for who actually survives, but it's hard to look at the heart on the left and say that that's a cardiac arrest, because the heart is moving. But if you have a moving heart and you have absolutely no blood pressure, as you have no circulation to the brain, then if it's not cardiac arrest, then maybe it's shock, the most extreme form of shock there is. And shock is always dependent on something. And shock is just a momentary pause in the process of dying. You can't just stay in shock. Either you die or you get better. And we can't treat shock unless we find the reason for shock. If we try and treat shock with just compressions, then we can just do that till the cows come home and nothing's going to happen at all. So we need to find the reason of shock. How are we supposed to do that then without being able to talk to the patient, because the patient is dead to the world? We can't take the person to cath lab because we can't do that intra-arrest. We can't take him to the CT suite because he's in cardiac arrest, and we can't wait for blood samples that take an hour to come back. Maybe we can do ultrasound. Everybody gets happy doing ultrasound. This is my son, and he's happy when he gets to borrow my machine. With ultrasound, we can find a tamponade, which looks like this. We can find AAA, an abdominal aortic aneurysm. We can find a pneumothorax, and you get happy just looking at these images. We can find free fluid in the abdominal cavity, and we can even find what is every point of care ultrasounder's wet dream, to find this massively dilated right ventricle that compresses the left ventricle, and telling us that this has to be a pulmonary embolus. However, as Spider-Man says, with great power comes great responsibility. In Sweden today, more than 90% of the people who survive a cardiac arrest do so with good neurologic function. And most survivors in most countries survive with good neurologic function. We can't make anything worse for those who survive well today. If we're going to do ultrasound in cardiac arrest, it has to be done in the right way, at the right time, with the right question, and it has to be quick. There's no image, no matter how nice it is to look at, that causes return of circulation. There are 2 American studies where they film all the cardiac arrest that have showed an increase in compression pauses of 12 seconds if ultrasound is performed with rhythm checks. And you remember the picture I showed you earlier about the coronary perfusion pressure, which drops down once you stop compressions. The same is in all likelihood true for the brain, and the brain doesn't appreciate being without circulation either. So if we're going to do ultrasound, then it has to be thought through and communicated in advance how we're going to do it, how long it's going to take, and who's going to make sure that we don't go over time. And we need to know what to look for. And you want there to be a list of differential diagnosis you could look for then, wouldn't you? And there is. In Sweden, we have the 4 H's and 4 T's. It doesn't cover everything. I found quite a few different. These are 6 H's and 4 T's, and you can have 6 H's and 5 T's, or you can have 7 H's and 6 T's, and none of this really helps. You don't want to think too much when you're really stressed. And if you're not really stressed when you're taking care of cardiac arrest, then you should check your stress hormones. So instead of being like the thinker, maybe we should try and be a bit more like Bob the Builder. He doesn't seem very clever, but things usually get fixed when he's around. And this is what we do in all other emergency situations. We try not to complicate things when we know that our brains don't work perfectly. And the thing we do then is we go back to the ABCDE approach, where we try and make a very, very complex and difficult task into small, tiny pieces that we do the same way every time. And Therese and I started talking about this 4 years ago, that we should be able to do something better for our PEA patients. And we didn't really think that 4 H's and 4 T's were much of a help. We thought that it's not reasonable to have a pneumothorax on the same list as hypoxia, as hypovolemia, because they're not equal. If you look in the registries, how many hypovolemic cardiac arrests there is compared to how many pneumothoraxes there are, they're not even in the same division. So what we wanted to do instead was to make an ABCDE approach for cardiac arrest. And I'm going to show you the Swedish version of this that is going to be implemented in the next Swedish resuscitation guidelines. I haven't translated this into English, but you don't really need to read this, just listen instead. So this has been revised maybe 40 times or so after we've had feedback from clinicians in various specialties and various researchers as well. And what's the main thing about this is that some things you don't really need to do. The A in the ABCDE here stands for ACLS, or in Swedish AHLR, which is the same thing. You don't need to think about hypoxia, just give oxygen to people. And if you have somebody who is in PEA, just give them fluids. Get somebody to take a blood gas, and then you don't need to think about that anymore. You'll get the electrolytes, you'll get the glucose. And then when you do the first rhythm check after you know the patient is in PEA, you have to do an ultrasound, because that's the only way to diagnose tamponade. And there's absolutely no point in doing that ultrasound unless you've thought a step ahead and thought about what you're going to do when you see a tamponade. There's no need to use an ultrasound machine if you haven't thought about doing a pericardiocentesis. The patient is dead. The patient isn't going to be any more dead if you do a pericardiocentesis and it goes bad. If you have a tamponade and you don't do a pericardiocentesis, the patient is going to die. So the first time most people do this, they probably haven't practiced it. I've done it once, I hadn't practiced it before then, but I had thought about it maybe 1,000 times, which was the reason why I dared try. That patient received ROSC, but later died anyway. She would definitely have died if we hadn't done the procedure. So the A stands for ACLS, B is for breathing, and what we're looking for here is pneumothorax. And we say in this algorithm that you should not do ultrasound for pneumothorax, which has caused quite a few people we like quite a lot to be quite angry with us because they really like doing ultrasound. And ultrasound is great for detecting pneumothorax. The problem with that is that it's probably too good. You have to pause compressions if you're going to do an ultrasound to look for a pneumothorax, and you have to sync it with ventilation. And then the sensitivity for ultrasound for detecting a pneumothorax is too good, because pneumothorax as cause of a non-traumatic cardiac arrest is probably really, really unusual. I've gone through the 14,000 cases that are in the Swedish cardiac arrest registry for in-hospital cardiac arrest since 2007. There were 2 cases of presumed pneumothorax causing cardiac arrest among those 14,000. But if we do ultrasound on somebody who's had good chest compressions, then we will be able to find a pneumothorax because we cause rib fractures, and rib fractures cause pneumothorax. So just think about pneumothorax. If you think there is a pneumothorax, just cut. Just perform, put in a chest drain, and then you've treated it. If you don't think of a pneumothorax, don't think anymore. You can look for the small pneumothorax that you might want to put a chest drain in once the patient has ROSC as a complication of CPR, but don't pause compressions to perform ultrasound. C is for circulation again, and here we want people to look at a pre-arrest ECG if there is one, and then we want to talk about finding a pulmonary embolism. And what we've written here is that you should look at the legs. If a person is in PEA and has a DVT, then you should probably give thrombolysis. We haven't written here to perform cardiac ultrasound for this, and this has caused even more people to be angry with us because they really want to do cardiac ultrasound to find the PE. Cardiac ultrasound is not a part of this for a few reasons. I want you all to look at these 4 images of a heart, which are taken from the subxiphoid view, which is the one that's easily accessible intracardiac arrest. Just take a minute to look at these. The right ventricle is at the top of the screen, the left ventricle is at the bottom of the screen. Which of these right ventricles are too big? I think that most people would agree that the bottom right ventricle is too large, it's bigger than the left. Some people will think that the bottom left ventricle is too big, and not very many people would think that the images at the top of the screen show an enlarged right ventricle. If you now look as well at the timestamps on these clips, you'll see that there is a difference of 30 seconds between the first and the second clip. And these 4 clips are all of the same person, which is actually one of our registrars in the emergency department here in Skövde. I've just decided how big I want the right ventricle to be. And then I've moved the probe until I have the right ventricle as large as I want it to be on screen. So this is one of the reasons why you shouldn't look for pulmonary embolism intra-arrest with this, because it's quite hard to know if the image is perfect or not. The main reason not to do it, though, is this. It is that the right ventricle becomes enlarged when you're in cardiac arrest. Felipe Terán, who's on the image here, is an American emergency physician. He published a study of 33 patients where they did transesophageal echocardiography intra-arrest for out-of-hospital cardiac arrest patients. And they found that 57% of these patients had an enlarged right ventricle. And that was all cardiac arrest. There is a Danish research group who do a lot of pig studies, and they've showed that the right ventricle inflates and becomes enlarged within 2 minutes in all causes of cardiac arrest. Whether you bleed a pig to death, whether you give the pig an infarction or a pulmonary embolism or a hypoxic cardiac arrest, the right ventricle becomes large. And the largest right ventricle in this pig study came from actually hypovolemia. So it's hard to know if a big right ventricle actually is big or if the image is bad. And a right ventricle in the setting of cardiac arrest does not predict pulmonary embolism. So don't do this. It's just going to waste time, and it's not going to give you the information you think you can get from it. If you're going to diagnose pulmonary embolism by cardiac ultrasound, you need a lot more ultrasound skill, and you need a more extensive cardiac ultrasound that you can't do because you need to do chest compressions. But you can do an ultrasound of the legs. And if you can't do ultrasound of the legs, just remember to feel and look at the legs. You can be in the groin and in the knee for as long as you like without compromising chest compressions. And if you have a DVT, then chances are you're going to have a pulmonary embolism as long as well if you're in the setting of a PEA. It has been shown that the presence of a DVT is the single most important clinical finding that predicts pulmonary embolism if you're in the ED because of dyspnea. And it's reasonable to think that the same is true for cardiac arrest with a PEA, although that hasn't been shown and it's quite hard to study. If you have a DVT, thrombolize the patient. The one thing to know here is that if you do go down that road, if you give thrombolysis to a patient in cardiac arrest, then you've also decided that you're going to keep doing CPR for at least 45 minutes, because that's the minimum amount of time you need to give the lytics to work. And then once you've done these things, once you've made sure that ACLS works well, once you've taken a blood gas, once you've looked for tamponade, and once you've looked for DVT, then you've picked the low-hanging fruit here. And if you still don't know what's the cause of PEA, then you know that if you don't find a diagnosis, the patient is going to die. And if you compromise with chest compressions in order to find a diagnosis, then maybe it's reasonable to do so once you've done all the steps above. And then it might actually be reasonable to pause chest compressions in order to do a more extensive cardiac ultrasound, or even to look at the abdominal aorta if you think you have a vascular surgeon you could convince to operate on somebody who's in CPR. This has been quite hard for me to do this work because I love ultrasound, and the more I've read, the more we've discussed this, the less ultrasound has been in this algorithm. But I really think that there are really only two indications to do ultrasound within cardiac arrest, and that is to see if the heart beats or not, and then to see if there is tamponade. And this is also what's in the guidelines as of 2021. Ultrasound can as well be a prognostic help in this setting. If you have a person who's in cardiac arrest, you've done CPR for 20 minutes, and you see that the heart is still beating, I wouldn't want to give up on that patient. As long as the heart beats, I can use that to say that this heart is not dead yet, and there's still a reasonable chance to get this person back. I'd be very wary of using it the other way around to say that the heart stands still and therefore this person is going to die. The biggest study on this is called the REASON trial, which was from the US in 2015, Romelu Gaspari and colleagues, and they showed that people in PEA or asystole who had cardiac standstill on ultrasound, the overall survival there was 0.6%, which is really poor. The problem with using ultrasound that way, though, is that we don't agree on what's cardiac contractility or not. There's been a quite good study in the US as well, where they showed conference attendees ultrasound clips of hearts that were either beating or not, and the attendees had to say, is the cardiac standstill or not? And the problem with this was that they didn't agree with each other, and they didn't agree with themselves. They were shown 15 clips, or so they thought, but they were actually shown 5 clips 3 times over, and they couldn't agree with each other or themselves of which heart was beating and not. So I wouldn't use ultrasound to say that this person is going to die. I'm not going to waste my time with further resuscitation efforts, but I will use it the other way around in saying that the heart is still beating, there is still a chance I'm going to continue CPR here. There's always room to quit later, but you can't really start over if you've decided that somebody's going to be dead and you change your mind in 5 minutes. So in order to put all this together then in 2 simple messages, take care of the most difficult patients you have in a simple way, which is use an ABCD approach. And for the love of God, do the simple things maximally well within cardiac arrest. And that is just make good compressions with no pauses at all. Thank you for listening. I hope my English hasn't been too slurry. And now we'll see if there are any questions.
Okay, thank you very much, Erik, for an excellent lecture. I see there are a few questions. One was already answered as Georgios asked and already noticed that, but there is another one question. What about shocking with coupled defibrillators to get higher energy? Do you have any experience about this?
I've tried it twice. It worked once. It didn't work the other time. I have no idea if it was because of this or not, but there's something that's called dual sequential defibrillation that has been written about quite a bit in the last few years. And there are case series saying that if you have a refractory ventricular fibrillation, then maybe you have a bigger chance of cardioverting that person if you give 2 shocks really close to each other, but not simultaneously. And the reason for that is that it's believed that you need to defibrillate at least 95% of the myocardium to cardiovert. And if you have a large heart, or if the vector of your current is in the wrong direction, then maybe it won't work. So if you then place 4 pads instead of 2, and you shock really close to each other, then maybe that could work. The little evidence there is for this as of today says it doesn't work. But if you have somebody who's in VF and they're not snapping out of it, and you have 2 defibrillators around, by all means go for it. But there's absolutely no reason today to buy 2 defibrillators everywhere, because it hasn't been shown to be better.
Thank you.
Erik, this is more than a question, a comment from you by Alberto Marra, that is the chair of the Young Internists of the EFIM, and that first of all he thanks you for your presentation and make you his compliment. And he asked you a comment about if you know, because you know about this study, when you show that the issue about the right ventricle dilation during the CPR, if you know, or just would be nice to ask to the author if you don't know, if they have data about not only the right ventricle but also the right atrium, because as you know, the right ventricle hasn't a regular shape, and so perhaps to focus on right atrium can give more appropriate information. Just a comment from you about this.
I don't think so. I think that the atria dilate for different reasons than the ventricles, and a lot of people have a diastolic dysfunction, and both left and right atria dilate from that. Also, it would be reasonable for the right atrium to dilate in the same way as the right ventricle does, just by cardiac standstill, because it's a low pressure system and the muscle wall is weak in both atria. So I think that both atria would become big intra-arrest, but I don't think it has been studied.
Okay, thanks.
There's another one question about what is your opinion on the use of sodium bicarbonate during CPR, probably?
Yeah, the evidence for it isn't good. There's American out-of-hospital data that shows an association with worse outcomes if you use it. Then again, if somebody is severely acidotic, that's not a good thing either. And it's just observational data. I don't think there's a role for routine use of sodium bicarbonate. specifically in the context of PEA, if you have any suspicion whatsoever at all that this might be an intoxication, then definitely go for it, because if you have taken a tricyclic antidepressant, then you kill two birds with one stone if you give it. But the little evidence there is shows an association between worse outcomes and sodium bicarbonate. So not for routine use, I think.
So we have another question that this is regarding a possible scenario that we have. For example, this is the question. So if you have to continue the HLR 45 minutes after thrombolysis, how long can you wait before you give thrombolysis? For example, if there has been long CPR in the ambulance?
So how late is it reasonable to give thrombolytics? Is that this, we don't know. There's only been one study where routine use of thrombolytics has been tried for all-cause cardiac arrest, and that didn't show any benefit at all. If you think somebody has a pulmonary embolus and the person isn't the right person to die, then give it, because if you don't give it, he or she is definitely going to die. If you give it, then there is a chance, and it's not that expensive, and you don't have any sicker patients that can't wait 45 minutes. So I don't think there's a time frame where there's no role for it anymore. But we also need to know that most survivors from cardiac arrest, they get return of spontaneous circulation within 15 minutes. The survival is, the drop-off in survivors is huge at 15 minutes. There are very few survivors 45 minutes into CPR. There are not zero, but there are very few.
Thanks.
Thank you. Next question is from Vincent. What are the most important prognostic factors to consider for whether or not to continue CPR? Are there any studies, or maybe you can say your own experience?
Yeah, there are a lot of studies. The problem with this is that the Holy Grail doesn't exist. What you'd want is for something to say that this person has no chance of surviving. pH has been studied, it doesn't work. Potassium has been studied, it doesn't work. Ultrasound has been studied, it doesn't work. So there is no single thing that with an acceptable discrimination finds the people where further resuscitation efforts are futile. You have to consider everything. And then you have to consider how sick is the patient to start with, how long was it before CPR was started, how good has the CPR been, and then what is the pH and what is the potassium and how does the ultrasound look. But there is no scoring system, there is no single value that says that this person can survive and this can't. I wish there was, but there isn't.
Okay, thanks. We have another questions in the Q&A session. So what is your opinion on precordial thumb?
Oh, I would love to do that one time. I've never done it. I think if you stand next to a patient who goes into VTAC, I dream of doing this, actually, seeing somebody go into VTAC and then getting to do the precordial thumb, then maybe you can use it, otherwise you shouldn't. And there's also an argument to say that if you give a precordial thumb, you could possibly cause a VTAC to deteriorate into VF. I don't think that's been studied, but if I were to see somebody next to me who's on a monitor get a VTAC, I hope that I have the wherewithal to actually try a precordial thumb, just because that would make me feel like a hero.
Okay, thanks. And the time when you used it, was it successful or not?
I haven't used precordial thumb. I just dream of one day being able to do that.
Mm-hmm. Okay, sorry.
Another question, considering that in the last decades we observed a change in the guidelines with regard to the importance of the breath or the chest compression. So the question is, in your opinion, is it still necessary to encourage the 2 breaths per cycle during the bystander CPR? Maybe compression only is the way to go, or do you think that in the future the guidelines will suggest only the chest compression?
For people who know how to do CPR, I don't think the guidelines will change. For lay people, I think it's absolutely reasonable to do compression-only CPR. And this has been shown by Gabriel Riva, who's done his thesis on this, and a couple of studies. He's from Stockholm, Sweden as well. He's done some really good work on this. That shows that if you know how to do CPR, then ventilation helps.
Thanks.
I'm sorry. Thank you very much. Another question from Marta is actually the same what I wanted to ask. What about the mechanical compressors? Do you use it in intra-hospital context, or do you have any experience with these chest compression machines?
Yeah, we have, in my hospital, we have Lucas, Lund University Cardiac Arrest System, and that's the most studied one. It has been shown to be no better or no worse than manual compressions if you do good manual compressions. We did mannequin studies in our cath lab where we checked how good compressions were and found that in that setting with the fluoroscopy unit and everything, we were able to do manual compressions correctly 5% of the time, which is rubbish, obviously. So in the cath lab, we use Lucas from the start. Otherwise, we don't use Lucas routinely because it takes a bit of time to get it up and running. And there have been no studies showing benefit of Lucas over good compressions if you can do good compressions. If you see for yourself that you're going to do CPR for 45 minutes, if you're given thrombolytics, then absolutely you should use a mechanical device if you have one. But I don't think you should start doing it straight away. Straight away, you should go do good manual compressions.
Thank you. And
another question is, what's your experience about mechanical compressor? Do you use in intra-hospital context, or do you think that is better just for the extra hospital? What's your opinion about this?
The same thing, really. If you can do good manual compressions and you don't have to do them for too long, then use mechanical devices if you have them. Pre-hospitally, I think it seems really hard to do CPR in an ambulance, and it's a good thing to have the compressions there, I think.
Thanks. How about the use of IV fluids? Should we use them in any type of arrest or rather in PEA? And what kind of fluids should be used?
I don't think you should use them in VF. There's been an Australian study where they randomized people to get either 2 liters of saline or nothing. And there was worse survival if you gave them 2 liters of saline. I think in PEA, sepsis and hypovolemia are quite common causes of PEA, at least in the Swedish registries. And there it's reasonable to just empirically give fluids because that's the treatment we have emergently. I don't think it matters much which crystallide you give. There's been quite a bit published in the last few years about saline versus Ringer's lactate or plasmolite. And unless you give really large volumes, there doesn't seem to be much of a difference. You just use the crystalloid you have available to you, I think.
Thank you so much. We have a lot of questions. One another I see. What is the relation between the pupil diameter and during the light reflex and the CPR prognosis?
It's extremely poorly validated is the answer to that. You can't really do a neurologic exam on somebody who's just had a cardiac arrest and think that prognostication is going to work. You need to wait. If you're going to be certain about things, you need to wait 72 hours after ROSC. This has been shown in the TTM studies.
Okay, thank you.
I think that we have the time just for the last question, if you agree, Zora. And the last question is if you have an out-of-hospital cardiac arrest that is refractory to defibrillation, so do you think that would be, however, good to bring it to the hospital and try other resuscitation or not?
Definitely, I think it would be worthwhile to take a refractory VF to the hospital, because in hospital we can see if the potassium is high or low, and we can give a specific treatment for that, if nothing else. So okay. Absolutely, yeah.
I agree. Thanks.
Thank you.
Okay, thank you very much. I think the time is already running up, so we can finish for today. Thank you very much once again to Dr. Erik Ullemark from Sweden, who we are very happy that accepted this invitation to give this lecture. It was a very interesting and clinical, excellent lecture, and with also very wide discussion. So thank you very much once again, and thanks also to Christina once again for organizing such a wonderful webinar and managing this very great speaker. So thank you very much, and see you on the next webinar, hopefully soon. Have a nice evening. Bye-bye.
Thank
Bye-bye.
you. Bye.
Bye. Thank you.